we're lucky to have real experts in our community. And I'm going to turn over next to Roby Bhattacharyya, who has now this great tradition of bringing us all up to speed on what's happening with the pandemic. And I'll just say that it's not that Roby has like the answer for everything, but he has a remarkable ability to take really complex data and concepts and sometimes conflicting pieces of information and synthesize it in a way that at least makes it transparent and helps us understand what the issues are so that we can all make, as a community, the best decisions possible. So Roby, over to you.
Thanks, Todd. Thanks for the kind introduction, and thanks to everyone for your attention. It's sort of a shame to have to do this so often, but that's the world we're living in right now. So the last time I spoke with you was actually more recent than the last town hall. We had a community update about 2 months ago. So my goals for today are not to rehash what we covered there. That's available on video if you want to go back, but to actually think about just what's changed in the past 2 months. And so the topics I'm hoping to cover today are the sort of state of the pandemic, focusing on the US and particularly in Massachusetts, where most of us are. I'll talk about variants, although that's a little boring, it's all Delta, but that will reflect a little bit on how much that has changed and in what ways that has changed the pandemic. We'll talk about vaccines in the Delta era. So both waning efficacy that you may have heard about, the boosters that have come to be recommended as a result of that, and then some promising news on vaccines for children. And then I will close with my thoughts on from a medical perspective on the ongoing transition back towards work on site. So to dive right in, because there's a lot that happens in every 2-month interval. This is the state of the US. The last time I spoke to this group was right around here where my mouse is pointing in late July. And we had just started to see an uptick, not only in the US, but in actually each of the 50 individual states. And so I think we knew something was coming. And sure enough, it did, just as it had in India before and in the UK and Israel before that. And so cases skyrocketed, not quite to the peak of the midwinter, but surprisingly close for a summertime when we consider the US as a whole. And unfortunately, as has been the case all around the world, every other time we've had a case surge, we've had hospitalizations and deaths peak as well. If we look at Massachusetts, the status is quite different, and I've highlighted the percent of the entire population of each of these territories that's fully vaccinated. So that's all people, not just eligible, and that's fully vaccinated. Because I think it's the single most relevant metric to understand why things went differently. In Massachusetts, instead of getting back towards our winter peaks, we got back to about the sort of shoulder of alpha back in April. And seem to have plateaued. I'll say that a lot of states, not all states, are starting to come down from this peak now. Massachusetts is not really as convincingly coming down, but we're plateaued. But hospitalizations and particularly deaths did not accrue to the same extent that cases did in Massachusetts. If we consider the least vaccinated state, West Virginia, the picture looked quite different. So the cases did actually hit their record in July and August, I believe, and maybe into September, and as did hospitalizations, and deaths are well on their way. There are states right now where they are in what's called crisis standards of care, which is actually unfathomable. I heard about this in April 2020 when I was on service at MGH, and we were fairly overrun. I heard about this as a remote possibility, and it was traumatizing to just hear about. So to think that this is happening a year and a half in, 10 months after tremendously effective vaccines are available, is not something that should be minimized. But living in Massachusetts, it's easy not to see that because things are so different place to place in the US. And of course, vaccination is not the only thing that differs. I think it goes with a whole host of behaviors. But I think it's important to remember that there are the things that we do, the choices that we make change how this pandemic is visited on us. Just to underscore the relationship between the confounded relationship, but the relationship nonetheless, the association between vaccination and cases, hospitalizations, and deaths, I pulled the 7-day rolling average as of Friday, so the last day that it was available for each state, and plotted the 7-day average of cases, hospitalizations, and deaths against the fraction of the state's population that's been fully vaccinated. The relationships are clear. They are striking, and they get progressively stronger as you get to progressively more severe outcomes, right? So the least vaccinated state has more cases than the most vaccinated state, but it has even more hospitalizations and even more deaths. Again, this is not just vaccination, but I think vaccination is the single most important driver of this. This is seen throughout the world as well, and it's important to keep in mind that even our least vaccinated states are in a much better position than most of the globe right now. Moving on to variants. So it's all Delta. It's been all Delta since we last talked. And so in some way, we're still keeping an eye on variants. A lot of our colleagues here at the Broad are looking at this carefully, but there's nothing that's really shifted its dominance. It's greater than 99% of viral cases in the US are caused by Delta. Globally, it's over 90%. This may be an understatement. South America was the last place that Delta arrived at for some reason. But even there, it seems to be just sweeping through, just as it has everywhere else it's been. There's certainly, it continues to mutate. This is not to say this is the end state at all. I don't think anyone can make that claim yet. But so far, while there are lineages that sort of sublineages that are emerging, nothing is taking over that we've been able to see yet, and nothing with functional consequence yet. I think the corollary of this is to imagine the counterfactual, like the sliding door case where Delta did not occur, because this isn't out competition in the way that we normally think of. It's not Delta sort of infecting the same host as Alpha and winning out. Individually, the likelihood of being exposed to COVID remains on the low end, meaning you're typically only exposed to one variant at a time. And so Delta isn't like boxing everybody else out, it's just spreading. Other things are not. The reason I bring this up is just that I think a lot about how if it wasn't for Delta, the measures we've been taking, the vaccinations that we've been doing would be enough to drive everything else out, and we would be in a very different place. And we thought we were in that place 6 months ago, heading for that place 6 months ago, but things changed, and Delta was a completely transformative variant. And so the way in which it did that, again, I covered this a lot 2 months ago, but it's mainly because it's a much more transmissible virus. And it's really, even seeing the numbers, I didn't get my head around how much of a difference that would make until it came, or at least until I started seeing what it was doing to places like India. So the reason that this has changed the way that we're all living, despite these tremendously effective vaccines, is that vaccines are not perfect. They reduce transmission, but they do not prevent it. And especially with Delta, because Delta has caused so many more cases, while they make infection less likely, there is just a lot more virus out there now. And so infection is still possible in vaccinated people, and it's become more and more clear over time that even transmission from vaccinated people is possible. It's a little bit hard to put numbers on this. It's certainly less likely that a vaccinated person will spread Delta than an unvaccinated person, primarily because they're less likely to be infected. So vaccines are still protective against infection, and if you're not infected, you're not going to spread. It is probably true that if you do happen to get infected as a vaccinated person, you're probably less likely to spread than someone who's unvaccinated, but that's a little bit harder to pin down and a little bit less clear. I think the primary mode of preventing transmission is just not being infected as often. The other thing that's abundantly clear is that if you are infected, you are much less likely to get badly sick. Clearly vaccines reduce the risk of severe infection, even from Delta. But because of the increase in cases, and because vaccinated people are able to transmit, and because there's still people in our society not protected, either because they're not vaccinated, or they're ineligible for vaccination, or they're immune compromised, we're still in a place where we're asking for layers of protection, where vaccination is no longer thought to be enough to kind of do our part for the folks around us, and even for ourselves, right? Although we ourselves are with normal immune system are protected from severe disease. So this is kind of the Swiss cheese model, where vaccination, I think, is still the single most important thing, but that layering other mitigation efforts that we'll come back to as I get back to the return to work remains an important thing that we're asking folks to do. So a few fast facts about Delta. In the interest of time, I'm not going to belabor these too much, and I'm not going to present data for all of them, but I have references if you want to screen grab this and come back to it. It looks like Delta replicates faster than other variants in the body, in the nasopharynx. And this has a couple important consequences. It seems like the time to peak viral shedding is faster. It's a couple days faster than it was with the prior variants that we were measuring. And this means a shorter incubation period. This probably means you are sooner after exposure, you start shedding. It may mean that you have a longer period of pre-symptomatic shedding, although I guess I'd say that's a little less clear. But I think this is facilitating transmission. The other thing it's doing, and we'll come back to vaccine waning in a minute, but it's interfacing in an unfortunate way with vaccine waning, because vaccines generate an antibody response, and antibody response declines with time since vaccine. But once you see the virus, you make more antibodies again. You bring in, your immune system brings in the reinforcements. With Delta replicating a couple of days faster, your immune system has a few days less to bring those reinforcements in. And while it does so, and it does so in time to prevent severe disease most of the time, and other cellular immune mechanisms prevent severe disease, It seems not to do so as well to prevent that initial phase of shedding virus in the nasopharynx. And so we're spreading more than we used to. We'll come back to waning in just a slide or two. But it's important to remember that vaccines still are effective against Delta. In fact, when you do head-to-head comparisons against prior variants, it's only a slight loss of efficacy than compared to alpha or wild type as best we can tell. It's certainly less, and like a single dose of an mRNA vaccine is quite a bit less. But by the time you get 2 doses, you have a high level of protection, and it's only a little bit diminished for Delta. But there's so much more Delta around that little bit of breakthrough is causing many more cases and many more onward transmission events. They are especially effective, as I've said before, against severe disease. The flip side of that is that it has become clear, I think, since we last spoke, at least to my mind, there's some debate about this, but I think Delta probably causes more severe disease on its own than prior variants. So best study I've seen is from the Lancet here. It came out a couple of weeks ago, that there's about a 2-fold risk of hospitalization if you're infected with Delta than if you're infected with other prior variants. And the specific comparator there was Alpha, because that was the most recent one. There's similar data from Canada, from Denmark, and in pregnant patients from the US. Those citations are listed here. I found one citation that did not find this, but the preponderance of evidence, I think, suggests that there is a real and measurable increase in severity with Delta that accompanies the increase in transmissibility, which is unfortunate. And just to say it again out loud, there is still very little known about Delta and long COVID. This has been a hard area, but chronic post-infectious states have been a hard area to study for decades. This is unfortunately a known challenge. And with Delta being so new on the scene, it is still a relatively unexplored area in my mind. There's a lot of effort in that, I should say. So quickly, let's get to waning. As I think many of you have probably heard this in the news. The first observations that this may be a thing to worry about came from Israel. Israel has been sort of a glimpse into the future for a while. Earlier this spring, that was a happy glimpse, because this comes because they vaccinated the bulk of their population faster than most of the rest of the world, about 2 months in advance of almost anywhere else. They got to more than 50% vaccinated. And so we got to see them in the early summertime lifting restrictions before anyone else would, initially without much consequence in terms of cases. But by late summer, we were seeing infections, not just we were seeing Delta arrive, but we were also seeing infections becoming more and more common in the first rounds of folks to get vaccinated. And you can sort of see that here. I'm not actually going to go into a lot of the observational studies because many of them are confounded by the age-specific way in which we rolled out vaccinations and the simultaneous arrival of Delta. But it's important to point out that this has been observed. It's been fairly consistently observed, and that importantly, severe disease the protection against severe disease, shown here in this blue curve in data from the UK for the messenger RNA vaccines, does not seem to be waning in the same way that protection from all infection is. But I did want to, so I said I was going to skip the observational studies because of all the various confounding of the age of the people, the time since vaccination, and Delta. But I did want to go into one set of studies that I think is the most convincing evidence to me that waning is a real phenomenon that we will need to confront. And that actually comes from the original randomized control trials of vaccines. And for those not familiar with medical studies, I thought I would just break this down a little bit. This was the most transformative study a single clinical study or dual clinical studies that I've ever seen in my life, and hopefully that we all ever will. 30,000 patients for both either Moderna or Pfizer were randomized to get either vaccine or placebo about a year ago. And we have all seen this graph before. Within just a couple of months, it became abundantly clear that if you got placebo, you kept getting COVID. And if you got vaccinated, you just stopped. 95% efficacy. This was amazing. And it quickly became ethically untenable to keep folks in the placebo group. So they did what they had pre-specified they would do, and they did what's called crossover vaccination. So those who had gotten placebo, about 6 months later, got vaccinated. They got told, hey, thanks for participating in the trial. You got randomized to placebo, we're now going to give you a vaccine. And so in about February, everyone who got placebo the first time over a couple months span got vaccinated. And so now what we have is a group that was originally randomized, some of whom got vaccinated about a year ago, some of whom got vaccinated about 6 months ago, and then Delta showed up. And we started getting word from Israel that Delta was breaking through. And so the FDA realized that this was an opportunity to study, and it's not a randomized controlled trial, but a very carefully orchestrated kind of natural experiment building on a prior trial. And that what they asked both Pfizer and Moderna to do is look at the same period when Delta was doing the same things, cases were rising at the same rate, and these two groups of people who randomly had been assigned previously to either be vaccinated a year ago or 6 months ago. And what they found, both companies, independent populations, independent analysis, found that those who had been vaccinated 6 months ago were less likely over this later period of time to get infected than people who've been vaccinated a year ago. So in some ways, this is bad news, right? Because it says that we've known antibody titers have been waning. We've seen these observational data that might have been confounded. This is really, I think, the best data there is, that if as you get to a year out from your vaccine date, you are more susceptible than if you were only 6 months out. I say it's partly bad news because there's good news, I think, hidden in this. It says that Delta, despite its rapid kinetics, despite the fact that we can't boost an immune response, 6 months out, our immune response is still doing something, right? Because the second group had more protection than the first group. So getting vaccinated 6 months ago was better than getting vaccinated a year. That means the vaccines are still working to some degree. And I think that sets us up for the debate, the discussion about boosters. And this is a discussion that's been had by this FDA and the CDC recently. And I wanted to go over a little bit of data quickly. It's pretty detailed, but this is actually pretty rich data. This is Pfizer data. And my apologies, this actually comes from an earnings call. They mentioned some of the data in the FDA documents, but this is publicly available, is all I could find. And what you see is that antibody titers, shown here on the y-axis, in a log scale, importantly, so small differences are a big deal. 2 months after, or a month after the first dose, after the second dose, you have a lot of antibodies. But 8 months after the second dose, that has waned considerably. And what this shows is that the third dose boosts. It not only boosts you about 10 to 20-fold from where you were right before you got the third dose, it actually boosts you about 4 to 5-fold higher, actually up to 10-fold in the Moderna data, supposedly, than you were even after the second dose. So these are the highest antibodies that anybody's ever had. And I think that I think is what basically motivates, right? So there's a waning phase and then this boost phase. That I think is a lot of the sort of immunological science that makes people think that the booster might make a difference, right? Remember, this 6-month data was better than a year in terms of protecting against Delta. Now we're here with the highest antibody levels we've ever had. So maybe that makes a difference. There's some observational data, again, fraught from Israel, that suggests this may be true, that you get actually 5 to 10-fold protection from a booster compared to someone with 2 doses already, but 6 months earlier. Now, the people who chose to get vaccinated may be also more cautious. And so this is a little bit hard to, I wouldn't count on it being 5 to 10-fold, but I wouldn't rule it out either, because they probably wouldn't have just started to be cautious 13 to 14 days after they got their boost. And so some of this is biologically plausible. So anyway, with that and not much else, the FDA and CDC had to decide what to do. And I won't go into the details here, but I'm happy to answer questions in the chat after if you want, or sort of in other settings. But basically, there were recommendations for anyone over 65 or residents of long-term care facilities or other folks with either comorbidities or high risk of exposure to consider or are recommended to get boosters, depending on which group. And I think that I just wanted to sort of make the point, I don't view this as the first step necessarily towards perennial yearly boosters or every 6 month boosters. I think it is possible, it is actually the norm for inactivated vaccines to be boosted 6 months to a year after they're given. We didn't do this in this time because we needed to get immunity as high as possible, as soon as possible. We don't usually vaccinate during a raging pandemic. But it is possible this is just a dose series that needs a delayed boost. And so I think it remains to be seen how durable that spike in antibodies will be. It remains to be seen whether and for how long protection is accrued, but I think it's possible. And so I also think it wouldn't be such a big deal to have to get shots every year the way that we do for flu. It would be so much better than what we've been living through, but I wouldn't say that it's a necessity just because people are starting to talk about a third dose. What about folks who got other shots? And I think specifically Johnson & Johnson folks have felt left out of these conversations. There is finally data, but it is press release only, so I can't say much about it. But a second dose of J&J clearly increases antibody levels and protection according to the claims of J&J. The details are a little scarce, but it's sort of a 4 to 12-fold boost in antibody titer that they cite, depending on when the boost happened. And they also claim a fairly impressive boost in efficacy. I'm not going to go into the details because I haven't been able to dig into them, but it sounds quite promising. There's also some evidence, I should say, that Johnson & Johnson may wane less than messenger RNA. There was antibody data that I went over last session from Dan Baruch and colleagues, and then a new paper just a week ago or so, showing that that functional waning also seems to happen less with the J&J than with messenger RNA for whatever reason. And while there are some studies ongoing so that's for J&J boosting J&J. For messenger RNA boosters, supposedly there are trials underway, but I've seen no data. Similarly for Moderna, I know that booster studies are underway, but there are no publicly available data yet. It is true that antibody levels, the dose of Moderna is a little higher. The antibody levels for Moderna vaccination seem a little higher, and maybe the protection is too, especially in the Delta era. But there is, as I showed you, some evidence of waning here too. So unfortunately for these two, folks who got these two vaccines just need to stay tuned for now, but I don't think it'll be long before we start hearing about boosters there too. And I can't mention boosters without mentioning equity. Because for as much as I think am more optimistic than some that third doses might make a meaningful difference, there is no debate that first doses make a much greater difference to the recipient than third. There are still a lot of places in this country, there are a lot of places in this world that have not even had a chance to get their first dose, or if they've had a chance, they've not taken it. And that is not equitably distributed around this globe. And so I think I've had to deliberately separate my policy feelings from sort of individual scientific considerations. And I'd sort of encourage you to maybe consider viewing it in the same light, right? The decision you make whether or not to get boosted is a very different one than the decision that the US has made to set aside doses for essentially everyone to get boosted. And the individual decision needs to be made in that context, in my opinion. But it's a decision with some tension. And I wanted to acknowledge that. Okay, moving on to kids. You've probably heard that children are getting infected at a faster rate than they ever have before, both as a fraction of overall infections and just overall. A lot of that is Delta. A lot of that is the vaccination, the age stratification of the way which we vaccinate, right? The percent of child infections going up is very much a function of who we've vaccinated. And there's good news on that front, that the Pfizer vaccine looks good in kids age 5 to 11. Per press release, again, asterisk per press release. They give a third the dose that they gave to adults, and they've reported similar antibody levels. This is called an immunobridge analysis to the nearest group, age 16 to 25, where they actually have efficacy data. This is fairly routine in pediatric vaccine approval, that they'll not test tens of thousands of kids to prove efficacy, but they'll test thousands of kids to prove immune status and compare to adults who have had efficacy proven. There are very scant details in this press release about side effects, other than to say that per the company, it's similar to adults. And there has been a statement that there were no cases of myocarditis among the couple thousand kids who got the vaccine. There's FDA submission expected within days. So within weeks, then we should start to see the data that they submit, and we'll be able to sink our teeth into this a little bit more. I am strongly of the opinion that it's worth considering vaccinating kids despite the fact that severity is less there. I don't have time to go into that today, but I'm sure that I'll revisit that later as these become available. And in the meantime, the best we can do to protect children is to vaccinate those around them and to take other mitigation measures, like being outdoors, masking, distancing, and being in well-ventilated areas when we can when we're indoors. So that brings me to the last topic for today, which is mitigations and sort of thinking about on-site work. I'm not aware of systematic data of sort of safety of return to work in office settings. I think the best studied place though that mimics this is hospitals. And so there's a lot of study here. And essentially, I think that hospitals, at least in the US, show that safe in-person work is possible with careful mitigations. This has been true both pre and post vaccine and both pre and post Delta. And the way that hospitals have done this is universal masking that is reliably executed by healthcare workers, to be fair, who have been sort of masking in certain settings for their whole careers. But also most hospitals are well ventilated. The Broad too is a well ventilated space. Folks need to be encouraged to stay home if they're sick in a way that should have been perhaps true all along, but is far more true at this time in history than ever before. And now with many hospitals and the Broad, but though certainly not all, putting in place a vaccine mandate, I think these are the ways in which hospitals have stayed safe. I will say the pressure point at hospitals has been around eating. I know that was a question that we got. And I just want to acknowledge that it will be a challenge that does not have an elegant solution, especially as winter comes and it becomes harder to eat outdoors. And so all that we've done, when there are outbreaks in the hospital, they've been traced to break room behavior and sort of lack of masking as people are eating and drinking. And so this is hard, and this just requires sort of as much caution as one can take, and I don't have magic answers here. I will say anecdotally, I've been back working on site. My lab is an experimental one. So we've been back on site for months now, and I have felt safe here at the Broad. I've continued to mask in public. I'm in my office now with a mask off, but when I'm out, I mask. I felt safe. I did not feel safe in April 2020 at MGH, but this calendar year, I have through sort of understanding that mitigation measures like this seem to work. For those commuting, we got some questions about this and requiring public. I understand that vaccination practices will be different. Masking practices may be different. Esprit de corps may be different on public transit than here within the walls of the Broad. And so if you're able to shift your time to off-peak hours where it's less crowded, you may wish to do that. If that's not possible, you may want to up your mask game. This is a place where I would certainly at a minimum want a surgical mask for these trips. And you could consider, if you're on crowded trains, upgrading that to an N95 or a KN95, which are much more protective for the wearer. KN95s tend to be a bit more comfortable for those who are not familiar with the wearing. But again, this is the concept of the Swiss cheese model of layered mitigations. I'll not dwell too long on this. I've shown this slide before. And again, this is one that I've just sort of scrapped together. This is not official, but this is how I think about things, that there's a layer from sort of most to least important that I've color coded by things that are or are not under your control. So being vaccinated is I think the single most important thing you can do for your own safety and those around you, and sort of hanging out as much as possible with those who are vaccinated. Being outdoors, testing as much as you can. And then being in areas that have lower case counts or are better ventilated. Again, that's granted not as much in your control. Masking and then distancing. And then not on this scale, because also very important, is your immune status and age are the biggest drivers of severity, especially. And so those are things to keep in mind as you choose which of these above Swiss cheese methods to adopt. So a moment about what might be coming next. So I think SARS-CoV-2 is here to stay. That was probably true for all along, but I think Delta has cemented that. But it's important to keep in mind, so we've gotten a lot of questions about, does that mean we're just going to always do these? Or if it's here to stay, why are we doing any precautions anymore? Don't we just need to accept this? I think the real transition that's going to happen is that it's not going to be novel forever. Unfortunately, sooner than we want, I think just about everyone in the world is going to have an exposure to spike protein. I hope that's mostly through vaccination, but if it's not through vaccination, it will come through infection. And once basically everyone's exposed, then I think much of this pandemic changes. Similar to the way that we've seen that vaccination makes a big difference. I think once everybody's infected, reinfections or post-vaccine infections just are not the same as novel infections. Novel infections are what have decimated the world. And so I think that we'll be able to transition to a time with fewer restrictions, but I think this will be gradual. It will not be stepwise, and it will almost certainly only be true in retrospect. It is also unfortunately the case. I think elderly and immunosuppressed people will probably remain at risk for severe disease. They've been at risk for severe, say, influenza for a while, but I think this is just another thing that wasn't true 2 years ago in our world that will be true going forward. But I haven't talked about this as much. I think vaccines will help. Therapeutics are coming along. And I think part of the reason to keep these precautions in place is that we're learning more and more about monoclonal antibodies are really good. They may even have a role for prophylaxis for folks who know their immune systems are down. Antivirals are getting better. We're getting better and better data over time, and there are more trials ongoing, many of which don't work, but some of which do. Over time, we'll get better at managing the risk, especially as the population at risk gets smaller, and we get better at identifying them early. There may be more variants to come, but Delta has set a really high bar. So, outcompeting wild type in retrospect was actually fairly easy. It was not well adapted to humans. Delta is a really fit virus. So for a variant to matter, it's going to have to displace Delta. That may happen. I'm not saying it won't, but it's a higher bar than it used to be. Boosters, kind of stay tuned. I think vaccinations for kids will help us get to this next phase also, just by getting us closer to everybody being exposed. And if you're frustrated, everyone's frustrated. We've never done this before. That's why it's hard. That's why it's hard to set targets, and why I think we just had, I think it's reasonable to debate what the targets should be, but that has to be done with humility and with frequent reassessment, unfortunately. But the bottom line is, with precautions, with vaccination, with these other Swiss cheese layers, risks can be mitigated. And we know a lot more about this than we did a year and a half ago. The one other plug I'll say is get your flu shot. Flu was weird last year. It almost didn't happen. And so I think it will be a more important year than others. It will not be the most important shot you've gotten this year, hopefully. But I think it's an important year to get your flu shot.